Welcome, everyone, to our quarterly Global Health Compassion Rounds. This is being convened jointly by the World Health Organization's Global Learning Laboratory in Geneva and the Focus Area for Compassion and Ethics, or FACE, at the Task Force for Global Health in Atlanta. The purpose of these rounds is to explore compassion in various facets of global health and to offer encouragement to each other and to challenge each other. My name is David Addis, and along with my colleagues, we're really excited to be hosting this event. Thank you very much for joining us. Our theme for this rounds is compassion and palliative care. And those of you who are familiar with palliative care know that in many ways it embodies compassion in ways that are exemplary in the fields of medicine. And yet compassion can be a challenge when you're on the front lines in the midst of suffering. So we'll be exploring today the role of compassion in palliative care, some of the challenges and some of the fruits of compassion in that field as kind of an exemplar of compassion in medicine. We look forward to very frank presentations, some challenges, and wisdom from our esteemed panelists. I'd like to now pass it to you, Shams, for additional comments and welcome. Thank you.
Thank you very much, David, and greetings to colleagues from across the world. Really, really delighted that we are coming together to explore this critical and urgent subject today in our Global Health Compassion Rounds. So, as David has well highlighted, palliative care is special to many of us for very personal reasons, and it's an arena within which compassion flourishes. Today provides us with an opportunity to explore this together with a panel that has a breadth and depth of expertise and experience. And perhaps when it comes to quality of care, and you see some of these words from our Director General, Dr. Tedros, made a very simple, but what I consider a pivotal statement on quality in the Lancet back in 2018 on the launch of 3 seminal publications on quality of care that many of you will know of. And he said, quality is not a given, and it takes vision, planning, investment, compassion, meticulous execution, and rigorous monitoring from the national level to the smallest, remotest clinic. And these words really gave us an opportunity to explore the compassion equation over the last couple of years alongside our colleagues at the Task Force for Global Health. And in this next slide, you'll see that what we mean by the compassion equation is known to many of you. What we are always highlighting is the critical importance of awareness, empathy, and action. So really embodying these 3 mutually supportive aspects: a cognitive awareness of suffering, an empathy, an emotional resonance with the suffering person, and action, a commitment to alleviate that suffering. We believe that compassion equation is required at every level, from the point of care to the health worker interactions, to health facility organization, to district level organization, national level strategic direction setting, and of course the global discourse. But this always has an impact on the quality of specific areas. And today our subject area is quality, of course, of palliative care. And the subject is so emotive. It is something, again, that is special to many people for obvious reasons. Let's start with a video that provides us with the human side, which of course is at the driving element and the driving force for all efforts related to palliative care. I'm sure you'll agree that that really does give us a starting point for this conversation. With that, I'd like to ask my colleague, Dr. Marie-Charlotte Busseau, to give us some WHO perspectives on palliative care. Dr. Busseau leads the work on palliative care within WHO, within the Department of Integrated Health Services here at WHO headquarters. Marie-Charlotte.
Thank you so much, Shams, and really delighted to be with all of you this morning or this afternoon or this evening where you are. I'm really delighted to have this conversation with all of you. I think actually this video is definitely a good introduction to our conversation today. I just want to add a couple of words. As you know, it is now estimated that around 56, even more, million people need palliative care around the globe every year. And so just to give an idea of the magnitude of the problem, millions of people in need of palliative care, some of them, probably less than half of them in the last year of their life. They are adults, older adults, children, adolescent, and like in the video we just watched, they need different kind of care. What they need is also from an early stage of the course of their life strengthening illness. And it should not be limited to patients at the very end of their life. Despite the fact that palliative care was identified as a fundamental human right, as we know, not more than 12% of the people in need of palliative care actually have access to it. And on the other hand, we know that even in rather limited resources, palliative care can be provided. So what is missing? I believe what we need to do is really a cultural change. And that was actually acknowledged in the resolution, which was adopted by the World Health Assembly in 2014, with a number of concrete barriers for the development of palliative care. We need to address these changes in a very concrete manner, and this is what WHO has been trying to do over the past years, providing countries with some practical tools to put in place palliative care services, integrate them at the different level of care, and make sure that it's really accessible to the people who need it. It's a little bit like building a house. So you need to be focused on the needs and expectation of the people. So you build the house they want. It's about providing the right care at the right moment, as early as possible, with the right people trained to provide them, and also at the right place, depending on preferences. It can be at home or it can be in hospices. So the complexity of these needs of patients and their family requires to organize the services, to deliver them on the basis of people preferences. This cultural change is the foundation of the strengthening of palliative care. And I think the ground to make this cultural change happen is compassion. We need to build compassionate health services. We need to build compassionate communities to really identify and address the needs and expectation of the people. Actually, palliative care emerged in the history decades ago on the basis of this conviction. So I think today our panelists will help us to understand better the role of compassion in palliative care beyond the good intentions. We are talking about compassion in action, to create a new dynamic, to be innovative in ways to address the needs of the people, ways to make decisions, and address really this challenge in terms of increasing health-related suffering. In the field of palliative care, there is also every day a number of ethical issues to be addressed. I also believe that compassion is the basis to address the ethical dilemmas, including all the people involved in the decision, in the way to find the best answer. So compassion is probably the ground to build the house of palliative care for the millions of people who need it. It is the ethos of people-centeredness and respectful health services. Now, I really look forward to hear from our panelists to share their experience and discuss with all of you. Thanks again for being there, and over to you, Shaz.
Thank you very much, Mary Charlotte. Let's now move into the panel. I'm going to be introducing the panel in one go so that we can make sure that we know who the panelists are. We'll be turning first to Dr. Emmanuel Luyirika, who is, for the last 10 years, the Executive Director of the African Palliative Care Association. And his vision for APCA includes a strengthened evidence base for advocating for policy development and change for palliative care across the African continent. So he brings a depth of experience there. We'll then turn to Dr. Phil Larkin, who holds the Christian Gerhard Jepsen Chair of Palliative Care Nursing at the University of Lausanne. And he has over 30 years of clinical and academic experience in the palliative care sector, and he was president of the European Palliative Care Association from 2015 to 2019. So again, a depth of experience. We will then turn to Dr. Raja Gopal, who is the director of the Trivandrum Institute of Palliative Science, the WHO Collaborating Center for Training and Policy on Access to Pain Relief. And he is the founder chairman of Pallium India, a non-governmental organization working for integration of palliative care into healthcare in India. And then we'll be turning then to Rob Jones, and we're delighted that Rob Jones will be able to be with us. He's a passionate advocate for children's hospice care, and his advocacy stems from a personal experience with palliative care. His daughter Poppy has a limited life expectancy resulting from a rare genetic mutation. Incredibly important for us to hear from him. He's a trustee with the International Children's Palliative Care Network and works as the Chief Finance Officer in the UK government. So now we know who the panelists are, and we'll turn to each panelist for an intervention to share their thoughts with us. Let me turn first to Dr. Emmanuel Luyirika. Emmanuel, the floor is yours.
Thank you very much for that introduction and for the opportunity to be part of this panel. I'll talk about compassion in palliative care from the context of a low and middle income setting in Africa. As you've heard, APCA works within the African context. But let's start from the point of definition of compassion. If you go into the dictionary, you'll see sympathetic pity and concern for the sufferings or misfortune of others. And there is that word misfortune. It's so common within the setting. Suffering is so common. But compassion is a constructive response to suffering, as we know, to enhance treatment outcomes, to foster dignity of the recipient, and to provide confidence as we struggle to improve the quality of life. It focuses on both the patient and the family as well as the caregivers. And patients and healthcare professionals value compassion and they often perceive a general lack of it in some of the situations where they operate, especially within the low and middle income countries. Compassion for patients and for professionals, therefore, is a way of enhancing care, and it improves outcomes, it builds confidence. It's about doing good. It's about doing good to make the others better. And so is palliative care. Palliative care is also about doing good to the patient, to the family, to the community, and to the country. And uncontrolled pain and symptoms, as we know, cause extensive suffering among patients and distress among family members. And therefore, compassion makes us focus on making the interaction between patients and their carers a very encouraging and good experience to improve the quality of life beyond the usual. It can be at the patient level, at the family level, and even within the health system. It's something that should be encouraged. And for example, when countries in East and Southern Africa worked with us and the Open Society Foundations to add another aspect to care that was not there, developing legal and human rights guidelines in palliative care contexts, so that patients could be comfortable about what will happen to what they want to see while they live and when they are dead. Again, that was another example of an addition to strengthen the systems for entrenching compassion in the services that are provided. But we also have challenges, and within the poorer countries, at the patient level, you have a number of challenges, and you cannot talk about compassion without talking about communication, without talking about language, without talking about competing interests at the patient level, without talking about pain and symptoms, without talking about the complex conditions in which the patients find themselves with. And then you come to the family level and you have resources. The issue of resources challenges a compassionate response. The resources may be financial, it may be skills at the health caregiver level, at the family caregiver level. It may be an issue of space. You need space in which to provide the best care for your loved one. And that challenges compassion. If you see some of the circumstances in which the patients are situated, it becomes a challenge in itself. But at the same time, you're supposed to give that response that gives the confidence to the patient. The competing interests call for, again, for comprehensive responses to address all the needs that exist and to refer those that you cannot meet. But above all, to also share information with the patient, with the family members, and the significant others in that person's life. And then we come to the health workers. Often in some of the settings, we have health workers who have the skills, but we also have those who have inadequate skills. And that challenges their response, their ability to respond appropriately. And then you have the facilities. If the patients are not at home and they are in a health unit or they're in a hospice, the facilities that are available. If it's in the home, there are also facilities that are needed that may not be available. And then you have the health workers who may be overworked because of the rounds they have to do in several homes or within a given hospice. And then you have the challenge of access to medicines and technologies. It's very difficult to show compassion to a person and he's suffering and you do not have the pain control available. So that creates a challenge, and availing these medicines and technologies helps us. Availing the morphine in a formulation that the patient, whether adult or child, can take, helps to foster your response to the patient's needs. And then other resources to address the needs at the health facility or health system level. And when the health systems are not equipped for the service, that creates ethical dilemmas. It lowers the morale of the patients, of the families, and of the caregivers. And those are not uncommon within the low and middle income settings. And therefore, we need to equip the providers to support patients to maximize their comfort and quality of life for the time that they have left, whether long or short, to advocate for better resources so that we can make the palliative care responses effective and comprehensive. But also being compassionate is not only for the patient and the families, but also to the providers, because we know that those challenges that we are talking about also affect the providers. They cause burnout, they cause frustration. I can give an example here of John, who is a cancer patient on a palliative care program, and recently we were called that John has no access to colostomy bags. The money he has from his pension is enough to pay for a week's supply, and then the rest of the 3 weeks he has no access to colostomy bags. And this story is so common, and so you can imagine the family members who live with the patient, the care providers who go there, and everybody who interacts with the patient, and the challenges that come with that inadequacy of services. Compassion is then challenged to the core, and therefore linking that to the bigger picture and calling for more investment in patient care and palliative care in general. We therefore need to entrench compassion by properly planning for the pain and symptoms of patients, develop solutions for the complex situations, make sure that we have the appropriate means of communication with the patient, the family, and his or her significant others. And if it's a child, that we are able to address the needs of a child with such a condition. And also equipping the palliative care teams to ensure that they have the palliative care ethos, they have the necessary skills, they have the tools and means to do their work. And these are serious issues within the low and middle income settings. Thirdly, we need to clamor for and call for more investment in the healthcare system to make it work for the patients and palliative care teams, but at the same time, prevent burnout and reduce exhaustion and stress on the part of the healthcare workers. So when we talk about compassion, we talk about a need, we talk about needs, we talk about challenges, and we talk about the responses that we need to do to make sure that the patient is comfortable, is having a good quality of life, and that the healthcare providers are also equipped to provide the service, and that the resources are available, often limited resources. But having said that, it's the only way. We don't have another option but to ensure that compassion is entrenched within the palliative care responses we implement. Thank you very much.
Thank you very much, Emmanuel, for setting setting things out so beautifully. We'll come back to you for some questions for further reflections, but without any further ado, let's move along to Phil. Phil, coming to you.
Hello, thank you very much, everyone. First of all, I have to apologize. Unfortunately, my camera died 5 minutes before the conference began, and I'm not able to make it work. So I have a disembodied voice, but I'll try to follow up on some of the points that Emmanuel made. In preparing for today, I probably tried to think about this in 4 dimensions because I want to speak from the perspective of a professional caregiver and as a nurse who has a clinical job and an academic job. So I have the potential to see both sides. And I suppose my first question I ask myself is, why is compassion important in palliative care? I think that there is an assumption that we give palliative care with compassion, but it's quite difficult to measure that or to find what that actually means, even though it's very clearly an expectation on the part of the public that they receive care with compassion. And if you look at examples where perhaps care has not been good, and I mean, those of you in the United Kingdom will be very familiar with things like the inquiry into the Liverpool care pathway for the dying patient, where the word compassion or lack of compassion was used a lot as a criticism or a lack of public confidence in the way in which care was delivered. Now, what I found very interesting about that was that a lot of this was challenged at nurses. Nurses in particular were criticized for having a lack of compassion. And a lot of things were said, including, for example, the fact that nurses were now trained in universities and not at the bedside. So the public had some need to see compassion visibly demonstrated, and in some way it becomes a marker for when care is good or not good. The reason I think it's interesting for nurses is because the fundament of nursing is care. That is what nurses do. That's what they're trained to do. And there's a lot of link between care and compassion. Emmanuel mentioned here, the different definitions of compassion. And what I try to teach my students is, in order to have compassion, you need to have empathy. But empathy is the key that unlocks the door to compassion, because the compassion is only visible when you see the action. Marie-Charlotte mentioned the compassion in action, but you need to have some resonance with the suffering of other people, and the presence of suffering is essential in order for compassion to be there. And so the second question I ask myself is, well, how do we actually recognize compassion in palliative care? And I think those of us, again, the examples Emmanuel gave, and I'm sure Raj will give equally good examples of the suffering that we witness in society and in humanity, but of course in our day-to-day work with our patients. And an image that I use, which is very, I think, pertinent given what we see in the current humanitarian crisis in Ukraine. But if I can just take you back to the previous crisis in Syria, and you may remember there was this global photograph of the body of a young child on a beach who had washed up, one of the many children trying to escape from war. And in this same image, you see a soldier. And this soldier is looking and witnessing and bearing witness to this terrible situation. But what you see him do is he goes to the body of the child, he picks the child up, and he moves the child to a place of safety. And that is what we do every day in palliative care. We witness the suffering, we move to do an action, we pick up that person and we move them to a place of safety through symptom management, through communication, through whatever we do in our role. And I think that in a way, the message I have is that actually, to be compassionate, it's about small actions. You don't have to move the world, you just have to move yourself. Because the little things that you do make the difference. And Cicely Saunders always said that, the presence of another person is a place of security. And I think that that is a critical element of our compassionate being. The second thing I think that's important in recognizing compassion is the intuitive self. So when I was a student nurse many hundred years ago, we were taught that intuition was actually the first part of scientific knowledge, because it's what you perceive when you see the suffering of another person that denotes, okay, I need to do something here. I need to act. There's something I must do. But in some way, we've lost a little bit of that intuitive self. And if we can reclaim that, that intuition that tells us in the pit of my stomach, there's something not right here. I have to do something. I've got to challenge the system. I've got to make the health system work better. I've got to find another way for my patient. I think it will help our scientific self to develop more compassionate tools and methods for the future for care of patients. And so I live in Switzerland, but I'm Irish. My background is I live in Ireland. My home is in Ireland. And there we have a phrase in Irish. The translation in English is, you have to learn to listen with the eyes and ears of your soul. So it's not just about the science, it's also about a deeper approach, a deeper sense of feeling in relation to the care of your patients. And why is that important? And my third point is, what happens if we fail in compassion? And I think many people see palliative care as the ultimate expression of compassion. And if you fail in some way, either because the burden of care is too great, or your colleagues haven't seen the burden of care, the burden of suffering that you have taken on as a professional, then the burnout happens and it can be devastating. And I'm sure those of us who work in the field have seen the examples of burnout and the difficulty of recovery in that situation. Now, I just want to make a point. Some years ago, I did some interviews, and one of the people I interviewed was a lady called Mary Baines, one of the great pioneers of home care in palliative care. And she said to me, compassion is essential, but some days I just need to be a good doctor. And that's around self-care, knowing when you can do the extra mile and when you just need to do a good job. And there's nothing wrong with that, because I think the challenge in palliative care is that sometimes we put ourselves on a pedestal, or we try to do everything that we can. And when we can't do what we want, we feel that we have failed. The other thing I want to mention here is around organizations. I mean, one of the things I find quite interesting is how many of our organizations and our big hospitals use the word compassion within their mission statements and their values. And my question is, where do I see that in real practice? What do you do to demonstrate you are a compassionate organization and that you care for the people who care for others? Because it's a very good message to give to the public. We're a compassionate organization, but do you actually see that in practice? And so I suppose my final point then is, what do we need to do? Well, I think to be a compassionate practitioner in palliative care, you need to see it as a daily act of care and a daily act of self-care, not just a clinical outcome. Because you are the instrument of care in palliative care. You have all these tools, but at the end of the day, it's often that relationship you have with the patient and their family that makes the difference. You know, Henri Nouwen, the theologian, said, you are the difference you make. And so that's the thing that's important. You make the difference. I think we also need to learn to name compassion when it is and is not present, and have the courage to say, this is not good care, this is not compassionate. And we also need to be attentive to our demons. Karen Armstrong, who has written that, The 12 Steps of Compassionate Care, the theologian, she says that we have our demons, internal and external. And the external demons are the systems that we work in that aren't supportive. And the internal demons are the things that say, I can't do this, I'm not good enough, I don't know what I'm doing. Because we do know, we just need to trust a little bit in ourselves. And my final comment is, I mean, obviously, is to learn to be kind to ourselves. I think for practitioners, we need to learn kindness. I'm almost interested with my colleagues, not necessarily how many years of clinical training you have and how many qualifications you have, but what do you do in the fullness of your life that keeps you sustained? Because if you can find those things, it will help to sustain you in the work that we do. What is it that sustains you in your living? And the final point is, how do we pass this on and nurture the next generation of practitioners? How do we get them to learn from the many mistakes perhaps people of my generation made in not respecting this need for compassion? How do we get that message across? Because it's hard to teach compassion, but I certainly believe you can model it. And in modeling compassion, we can prepare our next generation of practitioners. So that's my contribution. Thank you very much indeed.
Phil, beautifully put, and you've given us a lot of food for thought. We'll be coming back to come back to some of those points in a little bit more detail in the discussion. So let's turn to Dr. Raj. Raj, over to you.
Thank you, Shams. Ladies and gentlemen, I would like to build on what Emmanuel and Phil and others said so far. I also, like Emmanuel, live in an environment of low income. And we do have starving people amidst us. Why? Doesn't the world have enough food to feed everybody? That's a reality. Let me tell you a story which will illustrate how compassion is translated to action and why the compassionate person will not be alone in compassion, thereby running the risk of burnout. 4 years back, World Palliative Care Day being celebrated in a large auditorium. The minister was there, senior bureaucrats were there. As the meeting concluded, as we all were walking out, me tagging along behind the VIPs, a 14-year-old boy came and tugged at my sleeve. And he said, "Mom is calling you." It turns out that he tugged at a lot of sleeves. That boy and his mom had come, hearing about a palliative care meeting, seeking support. I walked across to where the woman was sitting. She was blind, and there was an ugly dressing covering her whole leg. She was a juvenile diabetic and now a single mother of this 14-year-old boy. She had been living in a hospital for 3 months, not only for treatment, because she said she couldn't go back to her home. It was not fit to live in with her leg. So we started wondering what we can do about it. And one of my colleagues, a medical social worker, went across to where this woman was supposed to be living before she moved to the hospital. This, what looks like a chicken hoop, was her home. No wonder she could not stay there. And in the last weekend that she had spent there, on the Saturday, the boy has said, "Mom, I cannot bear to be hungry anymore. Let us kill ourselves." And the mom said, "Hang on there just for one more day. On Monday morning, I'll take you to the hospital. Somebody will feed us." And for 3 months, a sweeper in that hospital was feeding both of them out of her meager earnings. See the compassion. But that did not become contagious. We send out messages on the social media and ask for a few compassionate people, the community, to help. Money started coming in. And we got her eye checked. She had retinal surgery. After 4 years, she saw her boy again. We got a diabetologist to see her. And after quite a number of years, she started walking again, though with support. A compassionate person gave a monthly allowance so that she could have a small but clean home to live in on rent. The community made it all possible. What was happening here? Okay, I believe this image demonstrates what happens. When we seek help, there are a few people who allow their compassion, who give permission for their compassion to come out. They came forward to help. There are some people full of those demons that Phil was talking about? Who would not? But as these people did what they could, and as we gave visibility to what they do, and when we opened the doors, when I say we professionals opened the door to common people, to the members of the community, to come into the healthcare home and help. This line shifts, ladies and gentlemen. We have seen that time and again. The line shifts. More and more people become ready. And this was what we saw during the last quarter of a century of compassionate communities in healthcare in my state of Kerala, in India, which is being replicated elsewhere in India now. And Libby Solnow and colleagues have started compassionate communities in 30 counties in UK. It's happening in Canada, it's happening in Australia. We professionals keep our healthcare house locked. We do not allow the community to come in, though the Astana Declaration of 2018 reinforced what they said in 1978. Engage the community, involve them in healthcare. And in Astana Declaration, they said, give control over healthcare to the community. We can make it happen. We need not feel insecure. The community needs training, but more than they certainly need training before they can come into healthcare, but they need to be given permission to be compassionate. And to use a word that I think Shams used, we have to model the way. Model the way and make it demonstrable. And then the change happens. The community becomes compassionate. And when they support us, we do not run so much of risk of burning out, we get out of the feeling of total helplessness. And then this is what has happened. Then after 18 years, the state government came in, and now there are more than 1,000 nurses doing home visits to humble homes. The nurse is carrying the medicine tray, but a volunteer, 2 volunteers are carrying bags of food for the starving people who have been destroyed by the cost of healthcare. And this miracle can be made to happen and needs to be made to happen. My final question. So I'm talking about poverty, food, money. Is this all relevant only to low and middle income countries? I have never worked in a high income country. Never spent a lot of time there. My knowledge is limited. But when I visit hospices in the West, I see a lot of lonely people. They press a button and a nurse will rush in and help and go back. They are alone again. The sickness of loneliness can be terrible. It happens in our place also, but I believe it happens less in our countries. And there are lonely people in the hospices. There are lonely people, elderly people in the cottages outside. Can't we get them together? Can't we allow the community to come in and help? Maybe all this is not a problem of low and middle income countries alone. Maybe it's a problem of different kinds of sickness in various parts of the world. Thank you very much for listening to me.
Raj, powerful, powerful statements and thoughts. We'll come back to a few of those points to dig a little bit deeper. Rob, turning to you.
Thank you. And it's a privilege to be here today. If it wasn't for my daughter and her prognosis and her experience, I wouldn't have the opportunity to be here today. And also, it's a real honour to represent the ICPCN as a trustee, which is extremely empowering. From the perspective of a parent who is trying to work their way through the difficulty of coming to terms with losing their child. I think first of all, I would say that my own personal resilience has been truly tested with my difficulty in coming to terms and accepting my daughter's prognosis. So from her birth, there was a very low expectation of survival, which continued for several years. And her prognosis is still not good. But she's achieved many landmarks, and her 17th birthday is coming up in May. So I've had a lot of time to think about this matter, this issue, and this challenge from the perspective of the parent, and how I cope with the knowledge of what is happening. And 10 years ago, we had the good fortune to be introduced to a hospice, and it was a seminal moment in terms of how we felt in terms of our resilience as a family for not just coping with the idea of losing Poppy, but also from a pragmatic point of view of having someone to turn to. And the conversation was very different than any conversation we'd experienced in healthcare. And it's not that compassion does not exist within other areas of healthcare. It's just we experienced a much deeper level of compassion than we'd ever received before. And Philip's comment about learning to listen with eyes and ears of your soul really struck a chord with me, because there was something very personal and trusting about the relationships that we started to develop with the nursing staff in the hospice. Now, I've always felt, and I can't explain why, that the end of life should be given the same level of care and dignity of respect at the start of life. I mean, I think that was something that comes from my mother, if I'm really honest with you. I didn't expect to be in a position where I would be facing palliative care situation in a hospice environment with my own daughter. So then it became very real for me. What I also found was, and I do reference my mother in this, is that having been in a position where she pretty much single-handedly brought myself and my brother and sister up, whenever we had a problem, she would think about it and she would buy us a book. Now, in the case of my mother, this had covered things like Roman history, specific sports that we were struggling with, and her response to the situation we found ourselves in, given her health issues, was she bought me a book by Thich Nhat Hanh, who is a renowned Buddhist and peace activist. Now, this is a book that stayed on my shelf for several years. I wish I'd dusted it off a lot earlier. And what I started to find was that the compassion that I was, and my wife and my daughter and my family were experiencing from the hospice was something which I hadn't really been able to connect to myself, because I was so overwhelmed with the suffering. So I started to read this book probably around 2 years ago. And what became apparent to me from reading this book was that compassion was transformational, potentially. And I really pick up on Raj's comments in this respect. He mentioned about contagious compassion. He mentioned about the process of adaptation. And so my reflection is, what have I learned from compassion from the palliative care sector, from the nurses who have been providing care and support, not just to my daughter, but to her siblings and to my wife and to myself. our safety net, as I call them. And what I've found is that by trying to understand the compassion that I'm receiving, rather than take it for granted, but trying to understand it, what I've tried to do is see how that compassion can help me with my own personal resilience by developing compassion in myself and building up my levels of compassion so that I can be more resilient in the face of my daughter's condition, which means that I can better support her and my wife and my other children, but then also other people. I can give back. And I really wasn't sure whether or not to take up the offer of today because I was nervous about it. But it felt really important because it felt that I was learning something about compassion. And there was something which I didn't learn actually until I met Ashley, who invited me, in fact, to join you today. And what I hadn't realized was that although Ashley and I don't really know each other at all, actually, I'm based in the United Kingdom and Ashley's based in the United States. I know very little about Ashley and she knows very little about me. But we met for a short period of time on Zoom a couple of weeks ago and we made a connection. And what I realized was that that connection was compassion. And what I realized in that moment was that there was, and I really do like the terminology that Raj was using around being contagious, because actually that gave me an encouragement. It further helped me in terms of building my levels of compassion, because I'd realized that by connecting and by recognizing compassion in others and connecting with it, we help each other. And I think that's so important in supporting nurses, for those in management who are perhaps not at the front line and not at the coalface, that they understand that connection is so important in supporting nurses and then making sure that compassion flows through the organization. That can be difficult in a management position if you haven't got line of sight. That can be very difficult, but I think it really matters. I feel very, very strongly that my experience of compassion has changed my worldview. I feel very strongly that that experience, that from that first experience with the nurse from the hospice to the ongoing experience, I felt that what that did do is sow the seeds of compassion in me so that I could, through the help of others, realize how compassion could help me cope and be resilient in the face of the most difficult challenge I've yet to face in my life. And that, my friends, is my reflection on compassion.
Rob, on behalf of everybody on this call, just a big thank you for that very personal reflection, and really appreciative of the fact that you have joined us today. So we'll be exploring just a few further points, and I'll come to each of the colleagues just to maybe ask a couple of points to further clarify. So Emmanuel, you mentioned solution generation and the importance of solution generation. If you wouldn't mind thinking a bit about that and reflecting further. And Phil, you were highlighting the importance of making sure that you don't have to move the world, but you have to make sure that you move yourself. So if you could perhaps reflect a little bit further on that, as well as the point that you mentioned in terms of naming it when it is present and naming it when it isn't. And Raj, powerful commentary on the World Palliative Care Day and the tug. How can we make sure, or how can we enhance the power of global movements, but keeping it very grounded in the real? Because you've made a very clear statement on that, which is something that always comes up in our discussions at the WHO. And Rob, if I may ask you to come back to any other points that you wanted to highlight, particularly in relationship to this point about end of life and start of life, because that certainly is something that you were highlighting, the critical importance of looking at those two ends of the spectrum of life. So if I may turn to Emmanuel first and then come to Phil, then to Raj. Emmanuel?
Thank you very much for to my colleagues and everybody for this discussion. The point of solution generation that you've brought out as I talked to an extent, it's a way of life within especially a context of limited resources. As challenges emerge, solutions must be sought, must be designed, must be discussed, must be put in place. Just before I came on this call, I was visiting a home where somebody passed away about 10 days ago, and a situation has arisen because he didn't leave a will. And because he didn't leave a will, there are certain issues that must be done, and the documentation is needed for that. And it called for sitting together with the family, with the wife and a few of her friends, and sitting together around those issues, and then coming up with a solution which we must follow up tomorrow and the day after, giving roles to different people. When somebody is in a situation where they need palliative care, it's different. It may not be that you have to wait for the next day. You need to create to work out a solution that deals with the challenge that the patient is facing at that particular moment. If for example, he's not able to take orally, and yet you must administer the morphine orally, and that's what you have, then a solution must be found to get that morphine into the patient's mouth, whether you are going to do it in drops and bits. That must be done at that particular moment. There are bigger issues that may affect the patient, that affect the health workers, the providers of the service. Currently now in Uganda, for example, the cost of transport is going up, the cost of soap is going up, and yet these are two very important issues in palliative care. Soap and transport are two critical issues. So how do we keep going to the patients even when the transport has gone up? And yet, if we don't go to the patient, if we are not able to wash, if the patient's not able to wash, how will he or she know that we really care and we are concerned about that particular patient? So every effort must be made together as a team, working with the family of the patient and the other people who care to get a solution for that. At a higher level, it might be at government level. We are lucky at the African Palliative Care Associations that we are also able to work with governments. Recently, we were visiting in DRC, and they have access to oral morphine, but it's not free, it's $10. And you have it in a facility, and there are children in that particular unit, but they cannot access it because it costs $10. And $10 for somebody who earns less than $1 a day is a lot of money. And there is no way you can keep saying you are compassionate, you are helpful, and the morphine is there, and the child cannot access it, and it's very costly. So those are challenges that need an immediate response, but also a long-term response. And so working at short-term solutions, but also long-term to make sure that in the long term, we'll get something better. And that's how we worked with the team in DRC to come to Uganda, see how we reconstitute morphine. They go back and prepare a site, and now we are preparing to support them so that they start producing their own oral morphine. So it's both at patient level, as I said, at team level, at family level, and then even at national level to be able to sort out issues. And that happens every single day. I don't see patients for money at the moment. I do it as a volunteer when I go to see patients, I go as a volunteer, and you really feel pity and sad for the patients and their families, but you also feel sad and pity for the health workers whom we send to these homes to go with very limited resources, and they are meeting mountains of challenges in those homes, and they must be helped to get those challenges sorted. The speaker, we lost our Speaker of Parliament in Uganda this week. He passed away in Seattle, and the debate has been raging. But before he became sick, we had a meeting with him to advise us on how we can force or move government to allocate more money for palliative care. And he sat down with us. He was a very listening guy. He listened to us. We are from a number of civil society organizations, sat down with us, showed us how we can work through the system to ensure that government can allocate more money for palliative care. They can, and so it's at different levels, but we need to be open to discuss. We need to be able to listen. We need to be able to talk. We need to be able to engage people who may have more reach and more influence than us, whether it's at the home level, community level, or at government level. And I see this, it's not only affecting palliative care. We know people say, oh, why are you palliative care people making noise? We have many other priorities, but we don't stop, and we can't stop because we know what our patients go through, and we must find solutions for these challenges that we face every day. Thank you very much.
Wonderful, Emmanuel. Very, very clear and actually practical, structured solution generation. And I know that all of that will be captured in the report from this Global Health Compassion Rounds. And it's really great to hear that solution generation piece. Phil, turning to you, if you can, yes.
Yeah, I'm still here. That's grand. Yeah. So your first question was, how do you move yourself? Well, I think the point is the world moves itself anyway. So the world keeps turning. We're part of that world, and we have to see ourselves as part of that world. But in terms of moving myself in a compassionate way, it means that when I go to see the patient, yes, I have to have an idea of what I'm doing, but I need to be open to what will be there for me. And the first question I ask is, I wonder, not this is my plan of care, because I want to see where the patient is. And so I try to listen a little bit more to, when she said this, I wonder why she said that. I wonder when my colleague didn't respond, I wonder why she did that. It's that ability to try and listen in a different way to what's happening in the situation. But also, I think within that, it's also about the kindness that we show to each other. How often do we actually thank each other as colleagues for the work that we do? When we think someone's done a good job, it's almost like people associate compassion with selflessness, that we have to be this omnipotent, selfless being that gives and gives and gives. The risk is if you keep doing that and you don't replenish yourself, that's when you risk the burnout. So for me, the small actions that people do, they need to be acknowledged and rewarded. And many times I try to say, thank you. I couldn't have done that. It's important that you did that because it meant so much to the person. In terms of the second point about naming when compassion is and isn't present, well, I know Peter Speck, who was a very well-known chaplain in the UK, wrote this thing about chronic niceness. That palliative care is infected by chronic niceness. We're a nice people who care for nice patients in nice hospices with nice, systems. And we know we listen to Emmanuel, we listen to Raj. We know that the reality is not different. It's all very nice, and if you haven't got transport and soap, well, I mean, how nice is that? The problem is, I think, when I'm saying about naming, we have to. When compassion is there, we need to learn to appreciate it and to see it as part of what we do in our daily practice. But when it's not there, we have to have the courage to stand up and say, this is not acceptable. And I, in my role in the EAPC on a number of occasions, and the one example I'll give you is visiting a children's hospice in Belarus, where they literally, these children in this hospice had been completely forgotten. They were not included at the time in any of the healthcare system. And basically they were basically given porridge 3 times a day. That's all they had to eat. Okay. Now, some of these were like adolescents. They weren't little children, but they were all children with special needs. And the reality is, you know, I knew I had a responsibility to help the people there to put together an argument to say, this is not caring, this is not compassionate. And of course, many times the health ministers closed the door and didn't want to know, and, oh, you palliative care people, you're here again banging at the door, but there's more important needs. But if you have the capacity to have a voice because you have a position or a role, we have to learn to use that and name when compassion is not present, because we know what happens if it isn't named. And that's when things go badly wrong. Thank you. I think we've lost Shams.
If we have lost Shams, stand by.
Well, we come in and continue, because that was really inspiring what you were saying there. And Rob, I know you were going to have a final reflection as well, and some of those, that's, you know, really powerful personal message that you gave, and that story of connection and compassion bringing us together. Do you want to say any more about how that has shaped the way that you're moving forward?
Yes, no, thank you very much, and thank you for the opportunity. I mean, I think there was an interesting point that was asked of me around the comparison I made to the start of life and the end of life. And I just want to pick up on a point that Raj made about loneliness in palliative care in perhaps Western society. And I think one thing I haven't disclosed in the sort of journey I've been on is my attempt to use the experience and compassion. As I found myself, and this is a long story, so I'm not going to go into the story now. So I found myself running the children's hospice that my daughter was referred to for 3.5 years. As I say, it's a long story, so we'll go into the detail of it. But in terms of this idea of loneliness in palliative care, I think there's a significant cultural dimension around this. And if, for example, in the UK, you were to say to someone, would you like to come and celebrate the birth of a child? Most people would say yes. They would embrace that opportunity and express their kindness. If you were to ask them the same question around someone that was coming to the end of their life, I think I would find that the take-up wouldn't be so much, because psychologically that's very daunting for many people. Certainly in the society I live in, I say that within the society there are cultures where it's only natural to embrace death and celebrate it, even though it's sad. There is a cultural importance around it, and I think that that's a factor certainly in society. And the great thing about this conference is we're hearing voices. We're hearing global voices, so we're getting global perspective. And what you're then seeing is the disparity, and in what I'm hearing as well is in countries where there isn't as much wealth and incomes are lower, those societies are finding ways of adapting through compassion, finding ways with a huge amount. I mean, Emmanuel's determination comes across very, very clearly to me. to find ways around that and find the resources and do what it takes to help people. And I think that's really struck me in today's conference. So thank you.
Thanks very much for that. And if we may then turn back to Raj.
Shams, thanks. I was listening to all the conversation, and Rob, thank you for sharing that very important part of it. Why are we not compassionate? I think the reason is fear. We are afraid. We are fearful. We are fearful of taking somebody else's pain. Oh God, how will we do this? Our country is so poor. We don't have the resources. Of course, I do not have the problems of the magnitude that Emmanuel has. We don't have to pay $10 for morphine. True. But when we are afraid, we invent long words to protect ourselves. We have one phrase, therapeutic distancing. Very nice. I mean, very honorable. We can distance ourselves. How far? Distancing by 20 kilometers away and then with a brick wall in between? Distance. See only the images on the screen. Don't see the human being. That's the way gradually over 2 generations, the medical system has been transformed. Therapeutic distancing worked to a beautiful distance that can be as far away from the patient as possible. And we are afraid to close the gap. It's fear. And by demonstrating, I acknowledge the value of therapeutic distance. If I take all the pain of every patient and family and take it home, I cannot survive. I acknowledge that. I have to be compassionate to myself. True. Having said that, that brick wall between or concrete wall between the patient and me, I find unacceptable. And we have to overcome that fear by demonstrating this and making it visible. We go to college and high school students, engage them as volunteers. They don't have many of the inhibitions and fears that we adults have. They get in there and get things done. They clean people's homes. They feed people when they don't have food. I think the culture has to change. The culture of distancing yourself too much has to change, and therapeutic undistancing has to be brought in so as to make it reasonable and safe enough, yet not so damaging as now.
Raj, I think we're listening very carefully to what you're saying here, particularly as we start planning for next World Palliative Care Day, because this distancing from the global to the absolute local, I think that image of that 14-year-old boy will be in people's minds as we move into that. And thank you for those points. Phil, I just wanted to come back to thank you for your points. I just did miss for connectivity issues the last part of it, and certainly will be listening to that later. Colleagues, time is not on our side as is often the case, and I know that those that are listening would want to listen to all of you for the longest possible time. I just wanted to ask you for one take home for us to walk away with from your perspective, one key message that you wanted people to walk away with from this conversation. There's a huge amount that they'll walk away with, but one thing of point of emphasis, Emmanuel, starting with you and then turning to Phil.
Thank you very much for the opportunity again, and thank you, my colleagues, for your contributions. From this vantage point, being a compassionate team of workers and responding with compassion to the needs of people with conditions that require palliative care, calls for investment by governments, investments by individuals, investments by institutions into focusing on palliative care as a service and as a discipline and as an affordable and accessible facility for everybody who needs it. Thank you very much.
Clear, Emmanuel. Investment. Okay. Shall we turn to Phil? Your one take-home message?
Yeah, I think my message is please don't give up on compassion, because our world needs it, and the patients and families that we see will benefit so much from the small actions that we do. So please don't give up on compassion. It really is a catalyst for change.
What spot on, Phil. Thank you for that. Raj?
I would just quote the father of our nation, Mahatma Gandhi, who said, in a gentle way, you can shake the world. You can really shake the world forever only in a gentle way, with compassion, and transform the healthcare, global healthcare, from the monstrosity, I'm sorry to say that it has become at times, to something gentle and something beautiful, which will relieve, which will dare to look at suffering and relieve whenever possible. Thank you.
Thank you, Raj. Rob, turning to you, and then we'll come to reflections from Liz. So, Rob.
Thank you. I mean, my message would be that compassion sows the seeds of compassion, and that by watering those seeds of compassion, then it will grow. And I think that is, I think I'm hearing that really from all the panel, with the different perspectives we have. I'm just hearing that common theme. Thank you.
Thank you very much, Rob. And again, thank you for sharing from a very personal space. I'm going to turn to Liz, who many of you know, and actually she doesn't need much introduction, but Liz Grant is the professor and co-director of the University of Edinburgh's Global Compassion Initiative. And in the last 10 minutes or so, we'll come to reflections from Liz. She's been listening very attentively to the panel discussion. I'll then turn very quickly to Mary Charlotte Busso for any final points before coming to David to close us out. Liz.
Thank you so much. That was such a powerful time together. I just want to say a very few words of reflection on this. I think what we have seen is palliative care in its many shapes and forms across the globe. It presences suffering. It brings us into the midst of suffering. It helps us notice suffering. It helps us alleviate suffering. It helps us to work with families and move beyond the immediate suffering to think about a future. And compassion does that too. Compassion asks us how we show up, how we are fully present in the face of suffering. For me, the significant thing that it came across in all that was said was that compassion fills the spaces between, if we allow it to do so. Those spaces of loneliness, of fear, of anxiety, of determination sometimes, of, you know, I'm here and this person's here and I want to keep the distance in order to keep control. Compassion can fill those spaces and change the way that we work. And it does that because it enables us to notice suffering, to interpret it, to get behind, as Mary Charlotte said at the beginning, to get behind what happens with 56 million people suffering, but to understand that relationally, if we come together, there can be change, and there has to be change. And it gives us the confidence and the, I suppose, the strength, the internal strength to bring about change. Compassion sows seeds, and you talked about this. We need to think about the seeds of compassion. We can sow the seeds of compassion, but even sowing the seeds, it generates a harvest for further compassion together. There's something contagious about compassion if we allow it to flourish, because we alleviate suffering for a purpose, the purpose of flourishing and nurturing and bringing together. Compassion fundamentally is relational. It allows us to move beyond feeling with, to being with, to acting with, to caring together. And the key for me in compassion, and you've emphasized this again and again, it is about the togetherness, the compassion, compassio, the com part, the together with suffering. What do we do? I think we also have just said that as we fill those spaces together, some of them are about the small acts of being compassionate. We need to scale compassion up. We need to scale palliative care up to serve everyone, to ensure everyone has access. But there's something about those small acts of compassion. And alongside the small acts of doing, compassion also asks us to give the space for the small acts of asking, to listen to those who are asking. And if I can just close with a couple of words from, it's a poem from Reinhold Niebuhr, a theologian. In the stillness is a dancing. Nothing worth doing is completed in our lifetime. Therefore, we must be saved by hope. Nothing true or beautiful makes complete sense in any context of history. Therefore, we must be saved by faith. Nothing we do, no matter how virtuous, can be accomplished alone. Therefore, we are saved by love and compassion. Thank you, Shams.
Thank you, Liz. Beautiful words and beautiful thoughts. And thank you for that reflection on the panel discussion. Just to see if Mary Charlotte Bousseau, Mary Charlotte, would you like to make any points of emphasis here?
Thank you. And really, this is the kind of conversation you don't want to conclude. I think with all the words and behind the words, the images, the testimonies we have shared in this conversation, we have been actually building bridges. Bridges maybe not so visible, but real bridges to make these small actions really changing what we want to change in the reality we want to address. I'm really impressed with the openness and the power of what we have exchanged today. And I think it's really a privilege for an organization such as our organization to be able to have this direct interaction with people who have this experience from their family experience or their professional experience in the field. Maybe just one word. Let's continue to build these bridges. We need to be able to also, as Raj said, to change the culture of therapeutic distancing to a culture of undistancing and having a capacity to really exchange more regularly our experiences so we can actually make a differences. So thank you for this first step. I think we definitely have to continue building these bridges between ourselves to serve the people we want to serve. Thank you.
Thank you, Mary Charlotte. So before handing over to David to close us out, I did want to thank again the panelists for their incredible insights. It's really been a humbling experience, actually, just to listen to colleagues this today. we can never underestimate the power of human experience, and we can never underestimate the power of simple, small actions. So our commitment is to make sure that we synthesize the findings and the experiences that were shared today, and to make that available to others. So we will be doing whatever we can in our humble capacity to not give up and to continue to invest in palliative care with compassion as a core element. David, over to you.
Thank you. Thank you so much, Shams. I also just want to express my profound gratitude to the panelists and the commenters for just a profoundly moving time together. I feel inspired, encouraged, and really connected in ways that I wasn't 90 minutes ago. So this has been a deeply moving experience for me personally, and I just a deep bow of gratitude to all of you. Thank you, Shams, for your facilitation. Marie-Charlotte, you and Ashley for organizing the day today, and for the panelists again, thank you so much. As Shams mentioned, we will provide a report. A recording of our time together will be available, and we'll work on that and get it to you as expeditiously as we can. Thank you. I accept your challenge, Marie-Charlotte, this being a first step. Let's move forward together in supporting each other in this effort. Thanks again to all of you, and thanks for all of you who attended today and participated in the chat and in your presence with us. Thank you very much. Be well.
Thank you.